be talking on choriocapillaris and how does OCT angio help us in. So let's get back to very, very basic stuff. When we talk of choriocapillary ischemia or choriocapillaris inflammation, it could be of two types. Firstly, it could be because there is inflammation in the stroma like we have in VKH, or sarcoidosis for that matter, and these granulomas that are present in the stroma are compressing on the choriocapillaries, producing something like what you would see as these dark spots on ICG. Now, these dark spots are round, multiple, well-defined borders. So if you are seeing these round spots like this, think of this as not primary choriocapillary ischemia. These are not really areas of flow void. They are because the choriocapillaries are getting compressed because of the granulomas in the stroma. So why you want to know about these? Because you want to take care of these granulomas very fast. You want to give them steroids, get rid of these granulomas, and you would see them that on OCT, they will disappear, on OCT angio as well. Now, I would show you an example of case of VKH only on OCT angio. This is day one when you see a lot of these hypospots, which are indicative of underlying stromal granulomas. You give IV methylpred, and by day 5, you know, the vision is back. Everything looks very fine. You look at the OCT, and there is no fluid. But what happens is these dark spots are still there. Patients somehow stopped steroids, and you see on day 1, you see these arrowheads with these black dots appearing, and again on steroids and day 14. So you can use them as a marker for tapering your therapy to steroids because they will persist even after the OCT appears normal, vision is good, and fundus, of course, appears normal. Now we come to the second set of choriocapillariopathies, which is primarily ischemic. That is, choriocapillary ischemia is the primary event, and this is what we see in AMPI or in serpiginous. Now here when you see, these are not round and well-defined like you would see in stromal VKH. These serpiginous varieties, they are more geographic and completely hypofluorescent. What do we not know? What we don't know is that when we are seeing them in the acute stage, like most of my patients, of course, are TB serpiginous choroiditis. Now, when you see this, what we don't understand is it primarily an ischemia of choriocapillaries? Is it inflammation of choriocapillaries, or is it a combination of two? And why would we want to know that? Because if we want to know, is there a component of irreversible ischemia that results in suboptimal visual recovery? Or is there a component of predominant ischemia, which inflammation that is causing a secondary ischemia, and we want to treat this inflammation very aggressively, even though we are talking of underlying TB or something. We got to take care of this inflammation because we don't want to end up with irreversible ischemia. So we did a prospective longitudinal study which included patients with TB serpiginous-like choroiditis, and we kind of a multimodal imaging. So I'm going to just show you some of the highlights of that study, which is already published in Retina. So we had 10 patients that had multifocal variety of choroiditis and 5 patients that had this placoid kind of choroiditis. Now, let's look at the ICG. These are 2 of these lesions which were active. You can see them on autofluorescence, and here this is the whole placoid, which is within active edge. If we look at the OCT angio of multifocal variety, what we see that we do see these dark spots as you see on these arrowhead, and these correspond to the active lesions on OCT angio. So this is the correspondence between angio OCT and ICG, and we found that there was a very good correlation in the acute phase between what we are seeing on the choriocapillary slab of OCT angio and ICG. And this correlated with fluorescein of FAF also, so I wouldn't go into the details. So there was a lot of debate on NFAS OCT. For me, NFAS OCT is very important while you are studying angio OCT, because NFAS OCT image is going to tell you whether there is signal reduction or not. If NFAS shows there is some pigmentation, dark area, so what you are seeing on OCT angio may not be area of true void. That may be just signal transmission. So that's why I think they are both important. So what we found, what I showed you, there were hypo areas on OCT angio. Now the big question is, are these all flow deficit? So we took the help of NFAS OCT, and we realized that majority of them did not show any signal reduction on NFAS, which meant they were representing true flow void. However, in 2 patients, we did see some RPE pigment proliferation, which means they were not areas of true void. So this we published in 2016 in Retina. So the question which we still had in mind is the choriocapillary hypoperfusion that we were seeing on OCT angiography during acute phase, was it primary flow deficit because there is ischemia of choriocapillaries, or is it a secondary flow deficit due to inflammation, tuberculosis in this case? Because we have this eternal fight whether to treat TB SLC with steroids or no steroids. So it's only makes sense in giving steroids if we can show the reversibility of these dark spots. So we did a longitudinal study of the same cohort of patients and repeated everything, including the ICG, at 3 months, with a working hypothesis that secondary flow deficit should recover significantly compared to the primary at follow-up at 3 months. Now I will show you what happens. Now you look at the top, and this blue thing here indicates the area of flow deficit. Now this is a placoid kind of a lesion which you see in serpiginous. So you see at the baseline, and you see at, this is not 2, this is 3 months, where you see that there has been some improvement in the flow. The area of flow deficit has actually improved with time. In multifocal, this improvement was much more significant. So if you have these multifocal lesions which are dark, during the follow-up you can actually get the reversal of ischemia, because that ischemia is probably secondary to the inflammation and not primary ischemia of the choriocapillaries. So in multifocal choroiditis, in all the 10 eyes, we found flow deficit area decreased in size with therapy and resolved at final follow-up. And this is, I'm going to show you one patient with baseline. Yeah, I'm almost done. This is at 3 months. And you can see these areas totally disappearing even on ICG as well as on OCT angio. You can see from here to here. Whereas the one which was the placoid choroiditis was the bad one. Probably it represents the late stage of the disease, but you don't see the reversibility of flow. You just see the large choroidal vessels and atrophy of choriocapillaries. We interpreted that placoid form probably represents the late stage of multifocal variety, or maybe it's a different phenotype, but that's the phenotype that doesn't show reversal. It is the multifocal variety which shows reversal, and it's important to give aggressive immunosuppression and steroids at the beginning because you want to restore the flow as much as possible. Thank you very much.